We're here at the 10th workshop on adverse drug reactions and lipodystrophy. We're here with Todd Brown, who is with the Hopkins School of Medicine. He is an endocrinologist. But I think it's best if you just kind of talk to the issues that you know and what you are taking away from this conference. That would be important.
So, as an endocrinologist, I'm interested in metabolic diseases, and a lot of our diseases increase in prevalence with aging. And in the HIV population, we have an aging population, and so the prevalence of many of our endocrinologic diseases are increasing with aging, and bone disease is one of them. And some interesting things, I think, came out from the conference regarding bone disease. The first is the in vitro data that was done showing higher viral loads when you infect osteoblasts seem to impair osteoblast function. So osteoblasts are the cells that form bone. So I should back up a little bit to say that bone is constantly being remodeled. It's a very active organ. The bone is being resorbed constantly. Old bone is being resorbed constantly, and new bone is being laid down. And the osteoblasts are the cells that lay down the new bone. We know that the prevalence of osteoporosis is higher among HIV-infected patients, and the real question is why. And the traditional risk factors for osteoporosis, so age, low body weight, smoking, high alcohol use, family history of fracture, which gets at genetic issues, rheumatoid arthritis, steroid use. Those are probably, some of them are higher in prevalence among HIV-infected populations. The other issues are whether or not the virus itself or the immune response to being infected with HIV, or the anti-retroviral therapy, or I should say, the anti-retroviral therapy contributes to this loss of bone mineral density that you see. So the in vitro studies, I think, were interesting. There are some methodological issues that need to be worked out, but they suggest that high viral load impairs osteoblast function, which I think is important. And other studies have shown, in vitro studies have shown, that some viral proteins can affect this bone turnover process, leading to an imbalance between bone resorption and bone formation. So this one study looked at children and compared children in different stages of development and their bone mineral density in both boys and girls. And it showed that, at least in the boys, not so much in the girls, that the bone mineral density was lower at each of the stages of down the road. So I think it's a crucial issue among HIV-infected children to look at bone mineral density, to try to intervene to reach their peak bone mass. Through things, non-pharmacologic means mostly. The levels of activity were dismally low in this population, in HIV and in non-HIV. The levels of adequate calcium consumption were very low. Adequate vitamin D consumption, very low. So I think that it's very important to intervene when you can non-pharmacologically to build the bone mass. The other issue that came up is the bone mineral density changes during the SMART trial. So Andrew Carr presented data. There was a sub-study looking at bone mineral density. And the findings were sort of interesting in that those who remained on viral suppression, that is continued anti-retroviral therapy, their bone density decreased over time. And the decrease was pretty profound. And there was a comparison to change in the NHANES population, to normalize for HIV-negative folks, and it was similar to what you see in a postmenopausal woman, the yearly change. The other part of it was that in the interrupted arm, bone mineral density actually increased after drug interruption, and then fell sort of back down to baseline. And it was thought that in other diseases, for example, inflammation and untreated HIV is an inflammatory state, that the inflammation would increase bone turnover, favoring bone resorption, that it would cause osteoporosis. But there's a much more complex pathogenesis is emerging here, where you have that treatment itself seems to be is playing a role in decreasing bone mineral density, and that untreated HIV, I hate to use the word protective, but it's not as bad as you might think. And this data sort of echoes what a few studies have shown, including one that we presented at CROI last year, or this past year, showing a decrease in bone mineral density over time in anti-retroviral naive HIV-infected subjects who initiate an anti-retroviral regimen. And 3 or 4 studies have shown this now, that antiretroviral therapy, no matter what the regimen, is associated with about a 2 to 3% decrease in bone. So there's something about changing either the virologic environment or the immune environment, and my suspicion it's more the immune environment, that, that is playing a role here in decreasing bone mineral density with time. Or when you stop antiretroviral therapy, as we saw in the SMART study, an increase in bone mineral density. And of course, you know, there's the SMART trial and Staccato and some others have shown beyond any kind of reasonable doubt that interruption is not a good strategy. But it's interesting in trying to tease apart the pathophysiology of what's going on with bones that these findings were seen.
So the important message then, take-home message, is that people should do what they can through exercise, through good food, good nutrition habits, and so forth, good eating habits.
Absolutely.
And sleep, and all the things we know are good.
Right, right. So the important, a few important things. We know that HIV therapy is a good thing. We're unclear exactly how bad it is for bones, but it probably doesn't matter, because we need to be doing things. We know it's a good thing overall as far as patients' health, and we know that we need to be doing things to try to combat some of the issues with bone health. So the prevalence of vitamin D deficiency, for example, in HIV-infected populations and in the general population is sky high, somewhere between 50 and 70%, depending on what cohort you look at.
There was reports in this meeting on that.
Yeah, exactly. And it depends on how old the people are, what time of year it is, because it depends on sun exposure. But vitamin D deficiency is a huge risk factor. It's a huge risk factor not only for bone disease, for a lot of other outcomes. There's a poster here showing an association between low vitamin D levels and the risk of diabetes, for example. Outside of the HIV world, there's associations between low vitamin D levels and cardiovascular disease, between low vitamin D levels and certain kinds of cancers. So the vitamin D aspect, I think, is crucial. Getting enough calcium, so between 1,000 and 1,200 milligrams of calcium daily is recommended for everyone across the board. And
then in what form would that, would you obviously had some in your food.
Yeah, exactly. So it's always best to get the calcium in your food. An average 8-ounce glass of milk has about 300 milligrams of calcium. So what I generally do with patients is see how much, get an estimate of what kind of calcium they're getting daily in their diet, and then have them supplement. And most people require 500, 600, sometimes 1,000 milligrams of calcium to get up to that.
And once again, a lot is not better.
Exactly, and there's some evidence that a lot can be even worse.
Yeah, right.
That's right. So you want to stay in this 1,000 to 1,500 milligram range. The activity issue is crucial. So we know that activity, that stress on the bones, so the pull of the muscle on the bones, it has a trophic effect on bones. It increases bone mass. So the more exercise you can do, the more bone, and any kind of exercise is good, but exercise which puts weight bearing on the bone is probably the best. That's crucial. The other thing that's important for bone health and the risk of fracture is falling. And it's sort of a simplistic kind of thing, but you're not going to have a fracture in most cases if you don't fall. So balance training is important as well.